Hi, everybody. I'm going to give everyone a couple more minutes to join here quickly, and then we can get started. We'll just wait another minute or so before we get started. I want to make sure everyone has enough time to get through the link.
Jordan, there may be a few people over in Teams. I'd clicked on that because my Outlook had popped up as a reminder, and there was a few people there, and I told them I was coming over to check the Zoom.
Okay. Let me see if I can send something out really quickly. Sorry about that. Okay, I sent an update to those folks, so we'll just hope that they can join us soon. I want to go ahead and call the meeting to order. Good afternoon, everybody. My name is Jordan Crummett. I am the public health educator and the coordinator for the Overdose Fatality Review Team here at Knox County Health Department. I want to thank you all for taking the time this afternoon to meet with me and go over our February data. I want to go through, let's see here. I want to go through some introductions. So I will run down my list as you guys show up on my screen. If you could just say your name and what organization you're representing for the team, that would be great. I will start with Chris Thomas.
My name is Chris Thomas. I'm with the Knox County Regional Forensic Center, and I'm the chief administrator here.
Thank you. And Candace?
Candace Allen with the McNabb Center. I'm one of the senior directors over adult intensive programming.
Thank you. And Alicia?
Hey, I'm Alicia Verlindi. I'm with the Knox County Health Department. I'm an epidemiologist.
And Amy?
Amy Delinky, I'm the Substance Misuse Response Coordinator at the Knox County Health Department, overseeing the All for Knox initiative.
And Brian?
Good afternoon, Brian Wimbigler. I'm a pharmacist and assistant professor for UT College of Pharmacy on the Knoxville campus.
Thank you. And Genoa?
Hi, just want to turn my video on. I'm Genoa Clark. I'm with Choice Health Network here in Knoxville, and we work with folks mostly through our syringe exchange program.
Thank you. And Greg?
Hi, this is Greg Roberts. I'm the Drug Intelligence Officer with the Appalachia HUD.
Thank you. Karen?
I'm Karen Pershing, Executive Director of Metro Drug Coalition.
Thank you. Michelle?
Hey everybody, I'm Michelle Trofeter. I'm a public health analyst with the CDC Foundation working on the overdose response strategy.
And Phil?
Phil Major, Knoxville Police Department, with the Drug Related Death Task Force.
Thank you. And Sam?
Good afternoon, I'm Sam Lee. I'm representing the Knox County District Attorney's Office.
Great. Thank you so much. Is there anyone that I missed? No? Okay, great. I want to move into approval of the minutes from last month. So I sent out an email to all of you with the minutes from our prior meeting, from the January meeting. Does anyone have any corrections or additions to those minutes? No? Okay. Can I have a motion to approve the minutes, please?
Motion to approve.
And a second?
Second.
Any opposed? Okay, great. Minutes stand as approved. And then we will move into the agenda. So the agenda today, from here, we're going to move into the presentation of our data, our brainstorming and discussion section, and then we will go over action items and any other business for the month, and then we will adjourn. Does anyone have any additions to the agenda? Okay, great. Agenda stands. So I want to move into just a brief overview. I know we discussed this last month, but again, this is an open meeting format. So these meetings are being streamed on the Knox County Health Department website. So the public is open for viewing. I just want to make sure that's clear. If you do have any questions or comments at any time, feel free to unmute and say something or put it in the chat and we can discuss them as we go through. I just want to make sure everyone's comfortable using that. This we also discussed last time. This is our case selection criteria for our 2020 and 2021 data. This is just going over our age range that we've defined, which is 25 to 44 years of age. And that is based on data from the Knox County Sheriff's Department, as well as some data from some other reporting systems in Tennessee. I have on our next slide some data from those websites as well. So this is just showing the average age of incarcerated individuals in Knox County, as well as the average age of offenders. This is just going to give us a rough estimate of the age range that we're going to be looking at. Of course, as we move along, if we're seeing a lot of changes to this data, we are available and free to change that at any time. But for now, this is the criteria we are going with, and that's what we've used for this month's data. So this month, we are looking at 4 cases. They are from November of 2020, and this is information from the Regional Forensic Center. We don't have any additional data this month as our data agreements were just fully approved earlier this week. The ones that we have been so far, we're working on getting more of those approved, but for this month, again, we're looking at strictly data from the Regional Forensic Center and some community information. So moving forward, we're hoping to see more information, but for now, this is what we have. So I will just go through some of the brief information in aggregate form, and then we can move into our discussion. So our first section is age. As you can see, we have 3 cases that fall into the 25 to 30 age range and 1 case that fell in the 35 to 40 age range. This is based on cases that have been completed and meet our criteria for November 2020. As Chris told me, this was the exact number of cases that were fully completed and falling within our category. So we lucked out this month that it was in our 3 to 5 case range that we're hoping to look at. And this is just some basic demographic information. Moving forward, we have location of the overdose incident. As you can see, 75% of these incidents did take place at the decedent's residence, with 1 occurring outside of these listed groups, which are the decedent's residence, friends or acquaintances' residence, a hotel or motel, or a motor vehicle. Next, we have how were the drugs administered? And in one of these cases, there was evidence of multiple routes of administration. So you'll see a percentage increase here, and it'll add up to more than 4. So we have 2 with the evidence of vaping or vaporizing, 1 with evidence of snorting or sniffing, 1 with evidence of injection, and 1 with no information on route of transmission. Moving forward, we have substances known to be found at the scene. I know we discussed this in our last meeting, so I've started including this as its own category in this graph, and that would be kratom. And there was 1 case where that was found at the scene. 2 had prescriptions for the decedent, 1 with noted powder, and 2 with noted packaging. And all 4 of them had some other form of substance found at the scene that was not listed in this criteria as well. Just to break that down a bit further, between how many substances were found at the scene, this is just one way of showing if there was 1 or more than 1 or no substances found at the scene. As you can see here, 2 of the cases, there was only 1 substance found at the scene, and in the other 2, there were more than 1. And in none of them, there were none. For our toxicology results, this is our very large graph here. You can see we have alcohol, amphetamines, antidepressants, cannabinoids, fentanyl, inhalants was a new substance added in this group of cases that we did not see in the December 2017 data. We also have methamphetamine. Naloxone was found in 2 of the toxicology reports, as well as opioids. And we'll discuss more of the naloxone data farther along. Moving into more scene-specific data, this is bystanders present. As you can see, 2 of the cases, there were multiple bystanders present. At 1, there was 1 bystander, and at 1, there were no bystanders noted to be present. Of those cases, 2 of them fall into the category of other, which does not include friends, family, strangers, intimate partners, person using drugs, medical professional, roommate, or unknown. So they just fall into the other category. And the 1 case was a family member. Moving into the naloxone data, as you saw, there were 2 cases where naloxone was found in the toxicology reports, but based on the data that were given about the scene and the incident itself, there was only 1 where naloxone was known to be administered, which is part of our data criteria. Had we been given more information on the other case where it was found in toxicology, that might differ, but this is based on information that is available to us at this time. In that case, other family was the one who administered naloxone, and 1 dose was known to be administered. Moving into our mental health and suicide section, there were 2 cases where the decedent was known to have a mental health problem or diagnosis, and that does not include substance use disorder, and there were 2 where it was not noted. And in all 4 of the cases, none of the decedents were known to have a history of suicidal ideations, plans, or attempts. In substance use disorder specifically, it was a split. 2 cases were known to have a substance use disorder diagnosis and 2 were not known. You can see here that of the 2 cases, 1 had an unknown substance use history, so that information is not included, and the other had polysubstance use, which would be represented by this graph here. So that's why it says 100%. It's all indicative of the one case noted. So combining that information, we have our co-occurring disorders section. This will show kind of a overlap of those 2 sections. So we have 1 case where there was no known history of co-occurring disorders, 1 where it was substance use disorder only noted, 1 where it was mental health problem or diagnosis only noted, and again, that does not include substance use disorder. And then there was 1 where it was a co-occurring substance use disorder as well as a mental health problem or diagnosis. We have no criminal justice history on any of these cases, so these all fall into the none category here, as well as here. This is known criminal justice history in general, and this is 14 days prior to death, any known interactions with the criminal justice system. So as you can see with this smaller amount of cases, we're really highlighting those current gaps that we have in our data set. As I noted before, we do have 6 fully approved data agreements. Again, those didn't come until earlier this week, so we're still waiting to hear back on a lot of that data. And we will be collecting that data and inputting it into our system for use in the future when we do larger aggregate data sections. So these cases will be fully represented once we get those data agreements fully settled. But right now we're looking at our largest gaps in previous medical history, previous treatment for mental health, substance use disorder, and other chronic conditions, interactions with any of our community health initiatives, previous criminal justice information, child services, other services, social services included, and then any sort of economic, educational, or employment background for these cases is also not included as well. So in the future, we're hoping that once we have our data sharing agreement settled and we have that flow of data really down pat, that we will fill these gaps with data from your organizations and other community members and be able to present on that and be able to get a fuller picture on all of these cases. And over time, we're going to be assessing any of those trends or gaps in data that we are seeing and using those to leverage our brainstorming and discussion sessions. Before we move forward, does anyone have any questions or anything to add to any of this information I've presented so far?
Jordan, I think it would be helpful from my perspective that when you're presenting the data, and we've got 4 cases today, that maybe you break it out by case 1, case 2, case 3, case 4, so that we know which cases pertain to those specific data points.
I think that the way we have things set up now and the way we've identified in the public meetings to fully de-identify that information, I think that might not be fully possible because we don't want to, even though we're de-identifying all this information, we're not including names, dates, locations. I think that if we were to present case by case, we would kind of defeat the purpose of aggregate data. I think since our community is pretty tight knit, we might be exposing someone's information inadvertently by doing that. Okay. I think there are some sections where we could break it down a bit more, and I agree with you there, but I think that's one of those constraints we're facing right now. Does anyone else have anything? Okay. So moving into the discussion section, I really would like to get an idea of, based on the information that we know now, are there any sort of programs or services that you feel would be good to connect these individuals, or are there programs where you see could reach any of these individual cases that you have no known knowledge that they were accessing?
Jordan, can you repeat that again, please?
Yes. Are there any sort of programmatic or community services that these individuals are not known to have been accessing that you think would have been important for them to be connected with? They might be programs we currently have in the county, programs that you think should be more accessible, or programs that you think could be a possibility in the future.
This is Candace. I think overall there are several points in our community where someone can access treatment. We all know there's gaps in a lot of the different continuum for treatment. So I'm not sure if you're just generally, because not knowing these individuals and not knowing what they already, if they were involved and what they were involved in, I'm not sure if I understand the question. If you could just clarify a little bit.
Right. I think more in general, we're looking for more discussion on, as a group, do you think that there are aspects of maybe what you're involved in, or things that you think, things that are going on in the community that you think would be important for them to be involved in? Since we have no full known knowledge of a lot of our resources right now that they might have been involved in, I think just, yes.
So I noticed on one of your slides it kind of mentioned, either who administered Narcan or who was witnessed. And in all the cases, there was one where it was like other family was mentioned in all cases. So it seems like in most of these overdoses, there is some sort of knowledge of family members whatsoever. And we do seem to have some resources, needle exchange programs and things like that for the people who are actually using the drugs. But perhaps there is some training opportunities out there for families that don't know how to talk or don't know how to approach their family members that are using. So perhaps there's some better training out there for, I guess, the families to be able to, notate that. We see it time after time again, that the family had just taken, their son to a needle exchange program. So there's resources out there, but, better knowledge than I have. Maybe there's some other opportunities out there.
Thank you, Chris. I think that's a really good point. I've been noting that as well among our cases, that bystander intervention seems like a point where there could be some opportunity for intervention and programmatic things as well. I know there are services that exist in our county, but I think taking note that that might be an aspect that we want to focus on, or something we want to make note of in our cases, is something that would be good to do moving forward. Does anyone have anything in that realm that they want to speak on or that they know of?
So Jordan, is the idea going forward to fill gaps, we would submit our information to you and you would de-identify it and just plot it out on the graphs, correct?
Correct, yes. Yeah, so moving forwards, if I did have more information about any sort of behavioral health interventions that they've been involved in, any sort of community services they've been involved in, I can take note of that and distribute that information to you all, not in a specific case-by-case basis, but a number of people who've been accessing those services. That's something that we'll be discussing moving forward once we have access to that data.
So if I have access to data, should I have already sent that to you?
If you have a signed data sharing agreement and I have sent you the case information for this month, then yes, whenever you have that information ready, feel free to send it back to me. For those of you that don't have a fully approved data sharing agreement, I know that we've been working with some people on a case-by-case basis to get that approved and moved forward. If there are any other things that you all need from me or from Amy, as far as support in that matter, or if you have any questions or clarification needed on data sharing, please feel free to reach out to us. That's our biggest hurdle right now, is making sure that we can get all of those things signed and squared away so we can have a fuller picture of the data moving forward.
And sorry for monopolizing your time, Jordan. But also, will we get those cases with more advance notice?
Yes, this month was really short notice, and I apologize for that. Again, we just got those fully approved data sharing agreements back on Tuesday of this week, so it was a really, really short turnaround. Totally understand that a lot of that did not come in before the meeting. In the future, we'll have about a 3 to 4 week time period before the meeting where you'll be receiving the case information. I want to make sure everyone has enough time because I know we're all extremely busy to be able to pull that information and get it back to me. Thanks, Brian. Does anyone have any other portions of the data or sections that they think that more information would provide greater guidance to them? I know everyone has their own perspective on this. Are there certain areas of information that you think would provide more context for you?
So Jordan, I looked at the cases this morning and found some things relatively easily and had to dig for some other things. But for example, criminal justice involvement, I found some arrest records and that type material. So where are you getting your materials when you're talking about arrest records? Is that just Knoxville specific or is it nationwide?
Yes, that is Knox County specific information that we will be receiving. We currently don't have anything finalized yet on the PD front, but in the future, it'll be Knox County specific information.
So would it be of value to have records that are outside of Knox County, or are we just sticking to Knox County? Because for example, in reviewing cases just in general, if I pull a CSMD report and I'm searching contingent states and something pops up with an address that isn't included on this sheet, and they're the owner of that place or something like that, and then they've accessed services in another state, but they overdose here, is that a value, or should we just stick to Knox County?
No, I think that would be of value to note. There are areas of the data collection where it asks if services were accessed, if there's a time period. So if you have any time specific information that's from another county or another state, that would definitely be beneficial to have.
Okay.
I don't know if we're going to do anything around this. And Chris, I don't know what you all have access and what you've gathered in terms of talking to family members of those who have overdosed. But I think it would be really interesting, especially when you're saying that 2 out of the 4 do not have a known history of substance misuse, but yet they died of a drug overdose. So it would be interesting to see the perspective of those families who lost that loved one. Did they know they were using? How long did they know they were using? Maybe they didn't formally get diagnosed, so there's just some things that I think we can learn a lot through, contacts with friends and family. So I don't know if there's a plan on gathering that type of data, but I think that is sometimes even more important than criminal justice or healthcare data.
I know there are a couple OFR teams from other states that do informal and formal interviews with Mexican as well as acquaintances. I don't know if Amy can speak more on this about our current capacity for doing that or our capacity moving forward in the direct future. Amy?
You might need to mute Jordan. Okay, thank you. So at this time, we don't have capacity to incorporate that, although it is something that I know you guys spoke about last month and something that we're definitely looking into, as well as something that's talked about in the practitioner's guide on starting overdose fatality review teams. Is there a large echo that you guys are hearing?
Try again.
Is that better? No, it's the speakers. If I talk like this, can you guys hear me?
Okay. Yeah, they can hear you.
Okay. So yeah, just currently we don't have capacity for that, but it is something that we're looking into. the same way that we're looking into a lot of other components on how to bring this meeting to a place where we can talk about the confidential case information the same way that a child fatality review team would. So this is really the beginning stages for us in terms of what's going on. This is also really one of the first OFR teams in the state. And so we're also seeing challenges, not just from our area, but really from around the country too, and trying to work through some of those components. So any suggestions like that, Karen, and everyone else, we really want to be hearing those things and what is really meaningful. And Alicia ran the child fatality review team here for a while and brings a lot of that expertise to the table. But I think until there's really some state legislation, we see some states that have that to protect teams like this. But until that happens and until some of those difficulties that we're seeing nationally are kind of worked through, we're probably going to have to just slowly shift our process to encompass all of those pieces. But suggestions like that are really about quality improvement for this team, which those suggestions are just as important as any of the other brainstorming and discussion that you guys have about ideas related to intervention points or program ideas.
Thank you, Amy.
So Jordan, once all those data sharing agreements are back, will there be a forum where the team can meet and discuss the cases in totality, knowing which cases pertain to which decedents, or will it always be where we send you things and then you just de-identify everything and just submit a report?
As of right now, the second format that you're describing is most accurate for our team. Like Amy said, moving forward, we are hoping to make those changes to move towards a more case-specific and confidential process. But the way things stand now, that's not really a possibility. So I will be doing the best I can to pull these together and give you a overarching view of the information, as well as the number of services accessed and hopefully a time frame for a lot of those. I'm hoping that can give us enough information to move forward with some ideas or suggestions. And like Amy was saying, those programmatic suggestions are important to us as well. We're tracking all of this information, whether it be team-specific quality improvement as well as community-specific initiatives as well. So anything that we can suggest on that end is definitely something that I will be keeping track of and reporting on. Does anyone have anything else? Okay. Well, we are a bit early today. I know we had a smaller set of cases to review this month, as well as the added time with the data sharing agreement. So once I do receive all of that information from those who have an approved data sharing agreement, as far as these 4 cases, I will be entering that information into REDCap, and we have the opportunity to go through some of this information in the future as well. If that's something you all want to do with the more complete set of data, we can definitely do that. If you guys want to go over it next month, included with the cases, or if we want to do it separately, that's totally fine with me. I can send out a written report if that would be better for you all for this set of cases once we have the full set of data. And then we can discuss a portion of it at next month's meeting. Does that sound okay to everybody? Okay, so I will do that. Does anyone have anything else that they want to add? Any questions? Okay. Again, if you all have any questions or anything that you think of as far as data sharing process or anything that comes up for you when you're looking at this information, please feel free to just send me an email, call me. You all have my information. I have my contact information on the next slide as well. We are still working on getting those data sharing agreements finalized and approved. So if you do need any support from us on that end, please feel free to let me know. We have our compliance people on our end, as well as Amy and myself, who can help with any of that information. So feel free to get in touch with us. Our next meeting will be on March 11th, which is exactly a month from now. It'll still be from 3 to 4. And again, we're still going to be using the Zoom meetings. I'm going to try to change that so it doesn't give you the option to join a Teams meeting, so it's not confusing in the future. Sorry about that for this month. I'll be sure to double check that for the next one. And again, if you all do have the case information, if you could send me your data whenever that's available to you, please feel free to let me know if you need more time or if you need more information on those to pull things. And again, if you all need anything, please feel free to contact me or Amy. If there is no, does anyone have any other business to add? No? Okay. Well, seeing that there's no other business, I will adjourn this meeting and I will see you all next month.
Thanks, Jordan.
Thank you.